Welcome to chapter 16. So let's talk about the ears. So we're going to be able to list the anatomic landmarks of the external ear, describe the tympanic membrane, list the function of the middle ear, the inner ear, determine the type of hearing loss a patient may have, and then incorporate some health promotional activities or concepts when we teach our patients. The nurse is assessing the ear for an adult. How should the nurse perform the exam? Should the nurse pull the pinna down and insert the scope? Should we insert the scope straight into the ear? Should the pinna be pulled up and insert the scope, or should we tilt the scope to the angle of the ear? Tilt the scope to the angle of the ear. So for an adult, we pull the pinna up and insert the scope, so up and back. And that's number 3. Okay, so the ear itself consists of 3 sections. We have external ear, middle ear, uh, and inner ear. So externally, the external ear canal goes all the way up to the oval window. So the tympanic membrane is included as well, which is generally pearly gray. When we look inside the ear, the external ear canal, you may see a yellowish either substance or liquid. And the yellow, not quite yellow, it could be brown as well, is called cerumen. And the cerumen basically is protective of the ear. It lubricates the ear. So I know sometimes patients clean it out with like Q-tip, and then what happens is that they're pushing it back in the ear, creating an impaction zone. And then the ear canal, the ear canal actually has a S curve. So when we look inside the ear, we actually need to straighten it out. So that's why we pull up and back on the adult ear. The middle ear has some bones in it, and this helps us with the conduction of sound. The eustachian tube also helps create or help us with sound conduction. There's a eustachian tube that's in the middle ear as well, and it helps with equalizing pressure in the ear. And then, of course, the inner ear goes all the way through to the middle, the end, or all the way inside the ear itself, where you have the semicircular canal, which helps with equilibrium, or the labyrinth itself. And then sometimes this can be inflamed. It can become, inflamed with some substance, or maybe an ear infection or something causing an inflammation. And then it'll actually feed incorrect information to the brain, and so the person may feel a little vertigo, a little bit dizzy, but not quite there. Their balance may be off. Now this picture tells us a little bit about where the structures are located. So going from the external ear, so going from the pinna, looking down into the ear canal, we actually see the tympanic membrane outline. And then the middle ear, so the external ear goes up to the oval window. The middle ear has those 3 little bones in the center. So the malleus, the incus, and the stapes, these 3 bones are actually in the middle ear. And then from the middle ear, it goes to the inner ear. And the inner ear is the one that actually has cranial nerve number 8. That's where you locate that. And it has the semicircular canal, the vestibule. So in the inner ear itself, the organ of hearing is the corti, the organ of hearing, but it helps us to maintain a little bit of equilibrium if, inside the cochlea is not inflamed. this just shows us a little bit more specific on the inner ear itself. So back in the inner ear, this picture is just enlarged. We can actually look at the older window. We can look at where the stapes is joined to the bone in the ear. We sometimes have stapedectomy, which is that bone actually adheres itself really tightly to others, and we actually have that removed. But see what cranial nerve is associated in here as well. If you can find it, it's the auditory nerve. So cranial nerve number 8 actually is located in the inner ear. So how do we hear then? Well, two ways that we predominantly hear. We can hear through air conduction, AIR conduction, and then we could also do bone conduction. So we can take a tuning fork, activate it by just slapping the things in our palm, and then we try to listen in the ear and see what happens. And that is air conduction. So air conduction lasts longer than bone conduction. And bone conduction would be, as I say, touching a bone. So where you touch that bone is important. It would be on the mastoid process behind the ear. And that would generally go away before you can actually hear the stuffing. And if you see right on top of this canal is the cranial nerves. So your cranial nerve is also active there as well. So here's a comic for you. The gentleman on the right. I had my hearing checked last week. It turns out I have a hearing loss in one ear. The guy on the left. Which ear? My left ear. Oh, too bad. I'm lucky my hearing loss is in my right ear, said the other fellow. What difference does that make? A big difference. It saved my marriage. When my wife and I are in the car and she starts to tell me how to drive, I just say, sorry, that's my bad ear. So this proves to you that actually hearing loss can save your marriage. Just joking. Next slide. So hearing loss. Types of hearing loss. Well, hearing loss is anything that causes the individual not to actually hear things properly. There are two different types. So sometimes the ear is obstructed by something. So that would be a mechanical dysfunction so there's no conduction of sound from the external ear to the middle ear. What could possibly cause this? Well, think about children. They like to pick up objects, and what do? Either put it in their mouth or they put it in a cavity, like the ears. So maybe some kind of vegetables or object or toys that goes in the ear, and then of course you call them Johnny, Mary, and they sit right in front of you, and of course they can't hear you. Why? Because no sound is getting in through the tympanic membrane, right? So they have conductive hearing loss. Cerumen, which is the wax in the ear, can actually cause occlusion in the ear and then prevent the person from hearing. Especially if we clean the ear out and we are pushing the wax in, building the wax up, right? That could potentially cause a problem as well. And then we have the second type of hearing loss is sensory neural hearing loss. So sensory neural hearing loss generally is caused by just sort of getting older, if that makes sense. And we call a hearing loss that occurs because you're getting older or the person is getting older. It's called presbycusis. So presbycusis is hearing loss as we age. And that's basically because the hair cells within the ear are pretty much have become destroyed. And that could be from maybe loud music when they were a lot younger. Maybe the person worked as, I don't know, a construction worker doing the jackhammer on the street and you hear that sound all the time. Or maybe they're a person that was in the military that works in, say, the submarine by the engines, right? The turbines where you have that loud sound all the time. Or maybe it's medication that have been taken. And so these medication actually help destroy those hair follicles as well. And these kinds of medication are called ototoxic meds. The medications that end in mycin, MYCIN, like gentamicin and uh, other myosin ending meds like vancomycin, these are medication that can actually destroy the hearing. So the labyrinth or the inner ear gives us information as to where we are in space. And again, if that becomes inflamed, then that person gets out of kilter, right? That person may actually complain of like vertigo or dizziness. Now, if you've worked in a nursing home, you may have had this experience. A patient can be laying flat on the bed, like close to the ground to prevent falls, and the person would be saying, I'm falling, right? And they're flat. They couldn't be any lower to the ground because they're completely flat. But that is because the labyrinth is feeding wrong information to them. So they have problem knowing exactly where their body is in space. And then, so a whirling sensation would be called vertigo, and then a sensation of sort of staggering and spinning sensation. Um, Patients sometimes report like dizziness. So with infants and children, um, the inner ear basically starts developing in the fifth week of gestation. So this means that a woman could be pregnant without actually knowing that she is, and maybe taking medication that is ototoxic that could potentially cause problem with the ear, right? Or when the ear was being developed, this is when the medication is taken, and so it would cause problems with hearing. If the mom has a rubella infection during the first trimester, it could actually damage the organ of Corti as well and cause hearing problems. Now, the eustachian tube is shorter and a little bit wider than the adults. So think about a baby if they're laying down and sucking on the bottle, suck, suck, suck. All that is being pulled up toward the inner ear or the middle ear. And so sometimes you find that patients end up with an ear infection. And then middle ear infection, sometimes moms prop the bottle up on baby, which we teach them not to, right? So we don't prop bottles for the infant to feed, and that could potentially cause a risk for aspiration. And then in the aging person, some of the changes that we can actually see is that the hair, HAIR, in the EAR, becomes a little bit coarse and a little bit stiff in the older adult. And so that could actually impede hearing as well, make it a little bit more difficult to hear. The cerumen, I guess, one more time, could actually cause problems with hearing loss. We want to be sure that we're not pushing the cerumen back in the ear. So appropriate um, cleaning of the ear would be done. Now, we don't really need to clean the earwax out because as we laugh and speak and talk, the wax actually works its way up. So we're just cleaning the external ear canal and not trying to impact the cerumen inside the ear. So cerumen is drier when we get a little bit older, because remember, body water is lost. And then also the apocrine gland atrophies a little bit, so it does not necessarily produce the oily substance. Um, and so, of course, it becomes a little bit drier, and then it'll cause the cerumen to become a little bit more impacted. Again, presbycusis, hearing loss as we age, that can occur as well. And then after about the person reaches 50 years old, they sometimes can lose high frequency sounds. So here again is hearing loss due to something else, but related to a loss of high frequency. So when a patient reports that they're hard of hearing, what do we normally see? Well, can you hear me? Right? You'd sometimes see the person increasing their volume and trying to speak at the top of their lungs to try to see if the person can hear. Well, part of the problem is that high pitched, high frequency sounds are what's lost for the most part. And so these individuals are in a worse shape. They won't be able to hear you yelling. So you may have to speak lower and then try to speak a little bit more less quickly so that the person will be able to hear. So for infants, again, we want to teach mom not to prop the bottle because, again, the eustachian tube communicates to that oral nasal pharynx area, and so you may have the air actually going working its way up into the ear canal, causing otitis media or middle ear infection. Okay. Breastfeeding is the most important food for the infant anyway, so maybe it can be tried at some point by moms to help with their baby being appropriately developed, because breast milk actually provides all the antibodies generally to protect them if they are fed up to a year. Think about it, almost a year's worth of antibodies that these babies um, would have on board to grow up appropriately. I guess the start of that, because then they transition into like real food or different foods. Now, not every infant is breastfed, so just be aware of that. And then the type of cerumen, if you're African American and Asian, you have dry cerumen, and if you're Caucasian, um, wet cerumen. So I'm sorry, I'm going to back up a little bit. If you're African American and Caucasian, you have wet cerumen. Dry cerumen would be Asian and American Indian. So subjectively, we want to ask about any kind of earache, pain that the person may be having in their ears, infection, maybe discharge from the ears. How about hearing loss? We may also ask about ringing in the ear called tinnitus. We may ask about the patient having vertigo, right? Having themselves feel up to par. Um, and then, of course, self-care behaviors. So how do they um, treat their ear? Do they protect their ear when there's loud noise around? Or do they turn the music up and then listen to it? Have you ever been driving down the street where your car is vibrating and rocking because somebody else has their sound turned way up that you can hear with your windows up close? You can still hear on the outside. So, how do we know a person has hearing loss? Some of the things that we can actually do to tell us, or we can pick up on. If they have trouble hearing, they'll sometimes cup their hand over their ears to try to funnel the sound into their ears. right? Or maybe they've developed a monotone, so a single tone, simply because they cannot hear. And then um, sometimes we ask our patients if they, when they've noticed the hearing loss, and or what does it sound like? What does it look like? Now, some patients have a family history of hearing loss, and so they too will also struggle with hearing loss. So at some point, we're going to ask about for our patients, how do they prevent themselves from getting a hearing loss, which we should be doing at all times. So if there's a loud sound that we don't want to get into our ears, then we can actually use, well, turn our sound down, use earplugs to help us protect our hearing. With individuals, so they may be staring at our mouth intently watching us speak. So they'll be lip reading, or maybe they'll, when they're answering their questions, you're getting a sense as to they didn't hear what you said because the questions are all incorrect how they're answering. And then if they speak, they may sound a little bit garbled as well, or they may speak in a very flat, monotonous tone. So either one of those, you can't really understand what they're saying because they think they're speaking appropriately, but they're not. Say clean their ear. What do they use to clean their ear? So do they go in with a Q-tip to clean the ear? And this is no. Remember, your mom tells you not to put anything bigger than your elbow in your ears. Well, that holds true still. Um, so generally, the Q-tip is for the external ear, not the internal ear. Well, these last few weeks, I'm sure it's been a little bit different. So we asked the question, when was the hearing check? When was the last time? Do they notice that they've had difficulty hearing? Do they wear a hearing aid? And then how do you utilize the hearing aid is information that we need to find out. So in doing the assessment, then you want to inspect, palpate, percuss and auscultate. Are we going to percuss the ear? Definitely don't percuss the ear. So we'll start with inspection. What are we looking at? We're looking at the position of the ear related to the head, where that position of the ear is. Normally, the eye should line up with that imaginary line around the eye level area in the person's bite, a little bit above the tragus. So we look for size and shape of the ear as well. Some people have really large ears, some people have smaller ears. We're looking for any kind of tenderness in the ear. And the patient will let us know if the ear becomes a little bit. So when we go in to look with our otoscope, we're going to pull the pin of the ear, the fluffy part of the ear up and back to help us. For younger children, we're actually going to pull it down in order to straighten out the curvature for them. Now, if we use this piece of equipment, we have to hold it the appropriate way. So we're going to hold it depending on the ear we're in. We're going to hold it upside down to help us. And then it's very sensitive inside the ear, so you don't want to stick the person in the ear too quickly to cause potential problems. So the external ear canal, we look for any kind of redness in the ear, and discharge coming from the ear at all. And then for the tympanic membrane, we look at the characteristics, right? So where's the cone of light on the ear? Is it at the 5 o'clock area or 6 o'clock area? Not quite 6, but like 5:30 area. In order to help us, we're looking for a discharge. And if we look at the tympanic membrane, we're looking for color changes there as well. And the tympanic membrane should really be pearly gray. So that's what we're looking for, pearly gray with the tympanic membrane. And then the external ear canal, we look for redness from the external ear canal, and kind of discharge is we look at as well. Now, when we look at the cone of light, where do we see the cone of light? If it's in the right ear, the cone of light will generally be around maybe 5 o'clock area. And then, of course, what normal is, where the cone of light is. And then if we look at the cone of light from the left side or the left ear, we should generally see the cone of light at 7 o'clock area. But again, tympanic membrane would be pearly gray naturally. Now, how do we test for hearing acuity? Well, a few things we can do. We can screen a patient to see if they have any ear infection or hearing loss in this instance. So we can have the patient close one of their ears after you're looking to see that there's no obstruction. Have them close one of the near, and then in the other ear, close to the other ear, not necessarily in it, you actually speak 3 letters or words, and the patient should be able to repeat it back to you correctly. So that would be the whisper voice test, and then the waiver test, that would be the tuning fork. You activate it and then put it on top of the patient's head, and they should be able to hear it bilaterally, evenly. That way we know that there are no deficits, there's no hearing loss deficits. So that's the Weber test. And it's not as reliable, so we truly don't want to keep using that same one again. And then we can do the Romberg's test. Romberg's test gives us a sense as to how our equilibrium is. So where's the body position in space? So we can have the person stand straight up, arms beside them, eyes closed. And they should stand like this for a good 20 seconds, and we're actually seeing if they are, if any kind of like movement that is not safe. So they would start stumbling because they're unable to really right themselves in space. So that would be the Romberg's test, a test of vestibular apparatus or the cerebellum. So when we are assessing infants, when we're doing their hearing assessment, we want to be sure that sometimes we have to put our equipment in mom's ear or the caretaker's ear, just so that children realize that it's not going to hurt them. And then again, when we are moving the external ear canal, then we pull it straight down, right? For adult, it's up and back. And this is for children that's less than 3 years old. For hearing acuity of the younger ones, like babies, they can't tell us if they can hear, right? So we're gonna have to test it. How we do so is by using the startle reflex. So you give a quick sound like a clap, and then the baby would startle. And you see all both hands and feet, just flail in the air because they're startled. And that can tell you that they're actually hearing something. So that would be testing for hearing acuity for an infant. So in 3 to 4 months, if you do that again and they hear that noise, they'll actually start to stop, and then they'll be listening to that noise. And then when they get just a little bit older as well, 6 to 8 months, they'll actually start to locate that sound. So they'll turn their head and start to look for that sound. And then in Documenting, we want to document anything that the patient tells us. So subjective data, ear infections, I've had a discharge in my ear, anything they tell us we're reporting. And then objectively, what we see, what we feel, we are documenting. And then this would be the end of our slide. I do believe that your book also has some additional pictures to look at related to potential problems with the ears. And some HESI hints. How do we communicate? What if we have a patient that is hard of hearing? How do we communicate with this person? Do we allow them to read the lips? Do we use a pen and paper to write? Do we speak really high or in a low, soft tone with the person? Sometimes we may need an interpreter. We can use American Sign Language to help us with interpretation, especially when it comes to, asking health-related questions or maybe explaining procedures to the patient. And then just some HESI hints. What's located in external middle ear, what's located in. Thank you for listening to chapters 15. Any questions? We can pick it up in our Zoom session.